Okay. So for the next couple of days, what we're going to spend our time talking about is the function of the cardiovascular system, the function of the pulmonary system, and how those two systems are going to change their functions. We're going to learn about what is normal function, okay? How do we shift blood around, okay, in the body under normal circumstances? How do we bring oxygen in and get it into our blood under normal circumstances? And then how do those things shift as we begin to exercise, as we begin to become more active? And so there are really two important ideas that are going to underlie all of this, which is why we're going to spend a couple of days on it. One, there are some relatively significant and performance-wise powerful adaptations that take place in the cardiorespiratory system when you exercise a lot, okay? Especially when it relates to endurance type of exercise. And I told you guys, I think it was last week, that when we do endurance exercise, we can all get a lot better. It's a lot easier for us. We can get much better at doing endurance exercise than some of us can at like making our muscles bigger and those things. And a lot of that is because of the changes that can take place in the cardiorespiratory system. The other piece is we need to understand what normal function is, because remember that cardiovascular disease is the leading cause of death in the US. And so as we are inactive, as we become obese and things, there are going to be pathologies that will develop in the cardiovascular system. So we're gonna depart from normal function into abnormal function. And one of the best ways to treat that abnormal function is through exercise. And so we need to understand what normal is so we can figure out, well, when this goes wrong because I'm sedentary, this is why it's dangerous. And then also we can then, well, something has gone wrong, but I'm going to start exercising. How is that going to bring us back to kind of a more normal ability to function? Okay. So this is a really, really important topic. It's a really, really important system for exercising and for keeping us healthy. Okay. So the reason that it's so important is that the cardiovascular system is going to kind of change its function in response to what the muscles are doing. It helps us to supply the substrates and oxygen so that we can make energy in our muscles. It also plays really important functions in our immune response, and it plays important functions in regulating body temperature. Those second two things we're going to spend practically no time whatsoever talking about, but they are really important, okay? Many of the things that the cardiovascular system does are going to be to support the function of other physiological systems, okay? If cardiovascular function is not working correctly, then metabolism in the muscles doesn't work right. The ability to contract the muscles and move does not work correctly. If the cardiovascular system isn't functioning correctly, then cognitive function is going to potentially be impaired because everything relies on energy. Everything needs the oxygen and nutrients that the cardiovascular system are going to move around. Okay. So, as I said, it plays a very large role in exercise and performance. And there's going to be many, many really, really powerful adaptations that are going to occur in this system when we exercise. Okay. And so we will get into that a little bit. We may not get to some of the adaptation stuff today. It may be tomorrow before we kind of hit on some of those. Okay. All right. So I've broken down some of the primary functions into a list. For our purposes in this class, we're going to focus mostly on delivery of oxygen and nutrients and the removal of carbon dioxide and other waste products. We're going to focus really on those first two, okay? And when we speak of the cardiovascular system, we're going to talk about the three primary components, or the three primary tissues or organs, however you want to frame those things, okay? And that's going to be the heart, the blood vessels, okay? So arteries, capillaries, and veins, and then blood. We're going to talk a reasonable amount about blood as its own separate entity because the makeup of blood is going to help us impart a lot of really important functions in the cardiovascular system. Okay, so the heart is going to serve as a pump, right? It is a muscle, and it's going to contract, and by contracting, it is going to push and move the blood around in our body. Okay, and we'll get into how it generates pressure gradients and how the blood moves a little bit in the next few slides. Blood vessels serve as conduits or channels, or however it makes sense to you. These are the tubes or hoses in which the blood is going to move. So the heart contracts, right? And that's going to push the blood through the blood vessels, okay, through the arteries, out into the arterioles, down into the capillaries. At the capillary level, there's going to be diffusion and exchange of oxygen and CO2 and nutrients and things, and then back through the veins, the venules, and then into the veins and back to the heart. Okay? And we'll talk about how and why that occurs in the coming slides. Blood is the fluid, or the somewhat viscous fluid. We'll get into what is a red blood cell, why are red blood cells important, what is the role of hemoglobin, okay? But the primary thing that blood does is blood carries oxygen, blood carries a host of other things too, glucose, lipids, okay? Blood also is going to carry hormones or neurotransmitters and a slew of other things. But for us today, we're really just going to focus on transport of oxygen and carbon dioxide. Okay? So this is the heart, okay? What I normally would have everybody do is take your left hand, okay? Take your left hand. I'm going to try to turn this down ever so slightly. Put your left hand kind of right like so, with your thumb facing up at your shoulder, and the bottom part of your pinky facing down towards your hip. Take your thumb, put it right about here, put it ever so slightly towards the midpoint, okay? And that is about how big your heart is, and that is approximately the orientation of your heart, okay? For most of us, the heart is about the size of your fist, and it sits with its apex pointed this way and the top pointed up here. It's just slightly onto the left side of the center in our chest, okay? This is an anatomy class. I do not care. I do not care. You're not going to have to look at a chart and tell me what chamber is what. You're not going to have to tell me, right, how many flaps each of the valves have. You're not going to have to identify the inferior or superior vena cava or the aorta or anything like that for me, okay? All that I want you to know is the general flow of blood through the heart, okay, to the lungs, and then back into the heart, okay? So venous blood comes in from what I'm going to call systemic circulation. So venous blood comes back and first enters the heart from being out in your body on the right side of the heart. And it comes into the right atria. It then moves into the right ventricle, and it gets sent from there. When the right side of the heart contracts, it gets sent to the lungs, okay? Venous blood and blood on the right side of the heart has a relatively low, okay, oxygen content. It is relatively higher in CO2 and lower in oxygen than blood coming from the lungs back to the heart, and blood that leaves the heart and first goes out towards the tissue in systemic circulation. So venous blood comes back, right side of the heart, off to the lungs. At the lungs, there's going to be diffusion where at the alveoli, that venous blood that has gone to the heart gives up its CO2 and it's going to bring in oxygen from the lungs, okay? So now we had high levels of CO2, low levels of oxygen. Those two things have flipped. We have low CO2, higher levels of oxygen. Blood then moves back to the left side of the heart, into the left atria. It then goes into the left ventricle. Left ventricle contracts, and the blood is going to leave through the aorta, and then it's going to be out into systemic circulation, okay? That's all of that I want you to know, because we're going to talk about some cardiovascular measurements, some things, and what it really is getting at is what is happening particularly on the left side of the heart, okay? What is happening when the left ventricle is going to contract? How much blood is going to be in the left ventricle? How much blood is going to leave the left ventricle to go out through the aorta every time the heart beats, okay? We're going to talk about heart rate. Heart rate really is just how frequently is the left ventricle contracting. We're going to talk about something called stroke volume, which is how much blood every time the heart beats is the left ventricle moving out, how much blood leaves the left ventricle every time it contracts. And we're going to talk about something called cardiac output, which is just those two things multiplied together. So over the course of 1 minute, how many times does the heart beat? How much blood leaves the heart every time, or the left ventricle every time it contracts? That's cardiac output. So we're going to get into each of those variables and how they're going to be changed around, okay, and the things that affect them in the coming slides. All right? Anybody have questions about that? No? You're not going to get a heart to look at in lab. There's not going to be a lab practical. You're not going to have to identify anything. I don't care about chordae tendineae or semilunar valves. Y'all have to be impressed that I know some of these anatomy terms, right? As someone that's never had anatomy. I think I told some of y'all I've never had anatomy. I've actually taught anatomy and physiology, but I've never had anatomy, which was kind of a fun thing. So do as we tell you, not as I did, right? I don't really know how important that anatomy is going to be for you guys in the rest of your lives. Okay, so we talked about cardiac muscle a little bit during the skeletal muscle lecture. Cardiac muscle looks like skeletal muscle, okay? It is striped and it has very organized sarcomeres where you're going to have actin and myosin. It looks like skeletal muscle under a microscope, okay? Very, very tightly organized. Some differences in cardiac muscle in comparison to skeletal muscle is cardiac muscle has more capillaries that surround it, okay? And it also is going to have almost 40% of its cytoplasmic volume is mitochondria, okay? So if you look inside your heart, inside the individual muscle fibers in your heart, most of the inside of those fibers is mitochondria, okay? It's actin, it's myosin, there's some sarcoplasmic reticulum, and then basically everything else are mitochondria. And the reason that is that we need to use a lot of energy. We need to make a lot of energy to allow our heart to contract, okay? So think about it in this way. I'm going to look, we're going to ask, let me pull this up really quickly. I'm just going to pick somebody. Let's look here. Cameron, are you there?
Yes.
Okay. Cameron, do you mind me asking you how old you are?
I'm 21.
Cameron is 21. Okay. Cameron, how active are you?
I feel like I'm pretty active. I probably work out like maybe 5 days a week.
Okay, so that's pretty damn active. So good for you. So think about this, everybody. Cameron's 21. She's pretty active, so we'll say that maybe her resting heart rate is 50 beats per minute. Okay. So Cameron is, I'm doing math on my phone here because I'm not a human calculator. So Cameron, let's figure this out. There's going to be, how to do this. So 21 multiplied by 12 months, that's 252 months multiplied by, so 252, we'll just say multiplied by 30 days in a month. So that's 7,560 days, okay? And then in that, there are 24 hours in a day. There are 60 minutes in an hour, okay? And her thing is 50 beats per minute. So since Cameron has been born, a rough estimate is that her heart has contracted 544 million times. Okay?
Oh.
544 million times. Now, when we're not even counting whatever we were getting in utero, so we could add another, I don't know, like 8 months or thereabouts in there. My embryology of humans is not quite up to snuff on all of that, okay? That's assuming you just sat there and you didn't do anything. So you're probably looking at somewhere in the nature, if you've been active your life, 600 million contractions of your heart up till now. Can you imagine if you were sitting around 50 times a minute? You're just doing this. You've been doing this your entire life, okay? All you're doing, beep, 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 okay? Can you imagine how tired your bicep would be, okay? Or if you were doing squats 50 times a minute, right, for the entirety of your life, and yet, okay, and yet your cardiac muscle is never tired. It's never really fatigued, at least at y'all's age, okay? So we could talk about that my heart is tired, like as a psychological thing, right? Like many of us have been in that place, right? But from a physiological standpoint, that's because you have all of these mitochondria in your cardiac muscle, and you have all of these capillaries that go to your cardiac muscle. And so you can supply lots of nutrients and lots of oxygen, and you have this giant capacity to use that oxygen in the mitochondria in your cardiac muscle to make very, very large amounts of ATP. Okay? When we use mitochondria, we don't ever make lactic acid. Okay? Energy that comes from mitochondria does not cause fatigue. And so this is why this is a good thing, right? So imagine you're 21. Let's all hope that you're going to live maybe another 80 years or something like that. You're going to live to be 100. So you've got, that's another like 24 billion contractions left in your heart. Okay. So I hope that can illustrate a little bit about some of the most significant functional differences between cardiac muscle and skeletal muscle. Okay. And so when we get into some of the pathology, the things that happen with cardiovascular disease, one of the things that happens is we lose blood flow through those capillaries, we lose blood flow to the cardiac tissue. And so with that lack of oxygen, it does begin to make lactic acid, and we're going to get tissue damage and those things, and that's what causes heart attacks and stuff. So under normal functioning circumstances, the heart's really, really good at this. Okay? Does that make sense, everybody? Yes, no, maybe? Okay. All right. So the cardiac muscle has some specialized structures in it, these desmosomes and gap junctions that are going to allow, they're going to allow very tight kind of holding together of each individual cardiac muscle fiber to the next one, and it's going to let us easily spread action potentials from one to the other, which will make a little bit more sense in the next coming slides. Okay. So how does the heart contract? This is one of my favorite things for us to talk about. So I'm going to do this only because I can see you guys. Lindsay, can you do me a favor? I want you to think really, really hard, and I want you to make your heart stop contracting for, I don't know, for like 10 seconds for us. Can you do that?
No.
You sure?
Yes.
Okay. Can you think really hard and make it beat faster? How about that?
No.
Okay.
I mean,
do you guys want me to do something to make Lindsay's heart beat faster, or all of y'all's beat faster?
preferably no.
Probably no. Like we could ask Lindsay to like stand up on whatever her chair is, and I don't know, Lindsay, are you a singer? We could ask you to sing us a song, or I don't know. The other things that we could do, we could ask you, I don't know, to tell us about something that was really embarrassing to you at some point that you've ever done. That might make your heart rate go up. Or I could have you do some deep meditative breathing. We could all kind of sit. In doing that, I can lower my heart rate, okay? again, what I'm kind of joking around, but what I hope that illustrates is that cardiac muscle is not under voluntary control like skeletal muscle. Okay. So as we mentioned, Cameron's heart has beat, she's had, 600 million heartbeats since she was born. And she's never had to think about those ever. You don't have to think about every sort of 0.8 seconds contract, 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 contract. Can you imagine like how distracted you would be? Like if you were like, I'm talking to somebody and I forgot to think about making my heart contract and then I just pass out or something. It would be like being on a treadmill your entire life. You got to keep doing those things, okay? And so that's a good thing that we don't have voluntary control over our cardiac muscle. So if we don't have to think about making it contract and there aren't these motor neurons that go to it to make it contract, then how does that function? Well, the heart uses something called the cardiac conduction system, okay? So inside the heart, there is going to be a collection of nerve fibers, okay? And the primary one of those that controls how often the heart contracts is called the sinoatrial node, or the SA node, okay? The nerve fibers in that SA node have something called leaky sodium channels. And what happens is that they're always leaking a little bit of sodium, and so that means that they're going to spontaneously depolarize and generate action potentials, which makes the heart beat every about 0.8 seconds. Okay, so we don't have to have an external stimulus, although we do have some ability to provide some level of a stimulus to the SA node and to other parts of the heart to potentially make heart rate go up or go down a little bit. So I have some ability to make all of you make your heart rate go up or go down, even though it's not a conscious decision in some ways. You can make a conscious decision to alter your breathing patterns, and that may bring it down. Or you may think about something like, hey guys, we're going to get a test tomorrow, right? Or, oh, you're about to have a pop quiz, or whatever else it is that might stress you out a little bit. That will release epinephrine and norepinephrine and make your heart rate go up. So we call this process autoconduction. Okay, the fact that it spontaneously depolarizes and then we transmit that action potential around and around in the heart, and it occurs multiple times every minute. Okay, it occurs depending upon what your heart rate is, somewhere at about 0.8 seconds or thereabouts. Okay. Sorry, my wife is texting me. We had a crazy night with our daughter, and she is still not taking a nap this morning, which is a new thing for her. So we're kind of I'm getting text messages as little updates. So if she melts down again, we have to pause class for a few minutes and then go off. Okay. Questions about that? You guys have all, I assume, heard of the SA node, and we're going to look at the AV node and the bundle of His and Purkinje fibers and things that are going to transmit the action potentials with everything. We need to understand this because when we exercise, we're going to change the heart rate and we're going to change our stroke volume, and the changes that occur are going to be due to these increases or decreases in signals to the SA node and the AV node and the cardiac tissue. Okay, so I just want to make sure that we are all going to be on the same page with this, or some of the stuff that we do going forward is not going to make very good sense. Okay, so there are 4 components to the cardiac conduction system. So we have the SA node, which is contained here in the right atria, okay, near the top part of the right atria. So this is where what we often refer to as the pacemaker in the heart. It spontaneously depolarizes cardiac muscle, transmits action potentials very well. It transmits them along the membrane of the cardiac muscle. So this depolarizes, action potential is going to move along the membrane of the muscle in the right atria. It's going to come down. It's going to reach something here called the AV node, which is contained in the wall between the right atria and the right ventricle. Okay, it's also going to spread from there over into the left atria. It's going to be conducted along the surface of the muscle over into the left atrium. This is why the atria contract first. Every time we get a heartbeat or we do a cardiac cycle, you get atria, ventricle, atria, ventricle. And if you listen to a heartbeat, you can hear two sounds. You can hear the atrial sound, and then you can hear the ventricular sound. Once we reach the AV node, we're going to transmit down some nerve fibers that run down the septum of the heart. These are called the bundle of His, or the AV bundle. They run down here from down the middle into the apex of the heart, and then they turn. So they go down and they turn and they come back up. Okay, and when they come back up, there are all of these smaller fibers called Purkinje fibers that look like little fingers that wrap themselves around the ventricles. So the fact that through the ventricles we're going to get more transmission through these nerves than rather than across the surface of the sarcolemma. Transmission in the nerves is faster than transmission along the membrane of the cardiac muscle. So what this allows to happen is the action potential gets to the bottom, and then the contraction in the ventricles is actually going to proceed more so from the bottom up than in the atria. It's more of a top down kind of contraction. This is good, right? Because the pulmonary arteries leave the right ventricle on the top. The aorta leaves the left ventricle going up. So we're going to push like squeezing something up. Okay. Every day my daughter eats this applesauce in these little pouches, and she's not very good at it, but you got to squeeze from the bottom up to kind of work the applesauce out. You're working the blood out of the right and the left ventricles in the same measure. Okay. And so the anatomy here is going to be what's going to allow all of that to happen. Okay. So every time the heart beats, we have something called a cardiac cycle. And so a cardiac cycle is going to include all of the events between two consecutive heartbeats. Okay. And so in a cardiac cycle, each of the four chambers of the heart are going to undergo a period of contraction that we call systole, and a period of relaxation that we call diastole. Okay, so what typically happens is when the atria contract initially, so the atria are in systole, they contract. The ventricles are going to be in diastole, they are relaxed. That's going to allow us to squirt the blood from the atria down into the relaxed ventricles. Okay, then the atria will relax, and that will allow blood to come back into them, and then the ventricles will contract, and that will push the blood out to the lungs and out to the systemic circulation. Okay. At rest, depending upon what your heart rate is, okay, at rest, typically a cardiac cycle is about 60% of the time is spent in diastole. So you're spending a little bit longer period of time with any of the chambers being relaxed, and about 40% of the time with them under contraction. One of the things that changes with exercise is that as heart rate rises, the amount of time in between heartbeats is going to shrink, and the percentage of that time between heartbeats that the heart spends contracting versus being relaxed is also going to shift. Okay. And this is going to have some very important implications that we will talk about later on as it relates to why do you have sort of a maximal cardiac output. We're going to reach a period of time when the heart is contracting so fast that it's not relaxed for a long enough period of time we kind of max out the ability to get blood back into the heart. Okay, and we'll talk about that probably tomorrow. Okay, how are we doing on time? You know what? Let's pause here, guys, and we'll go ahead and we'll take our break, and then so take 5 minutes or 6. Let's come back at 11:40, and we'll restart and take up from there. Okay. Okay. Okay, let's get back to it. So, all right, so we finished talking about the cardiac cycle. So the next thing is an EKG. And I think you guys have all seen, hopefully, an EKG before. But what an EKG tells us is an EKG is simply a measure of the electrical activity that's going on in the heart. And so if you take testing and prescription class with us, you guys will learn where we put the electrodes. But in essence, I'll try to do this again without being overly kind of weird and creepy. But you can take and you put electrodes all around the heart here, okay? And then you put a couple on your back and you put a couple down a little farther down on your chest, and it is going to allow us to measure electricity coming off of the heart. And in doing that, it's going to have this very distinct pattern of cyclic activity, of these cyclic electrical signals that are going to tell us and let us interpret if the heart is functioning correctly. And if we put enough electrodes on, then we can also figure out if there's a problem. Is it in the right or left atria? Is it in the right or left ventricle? So what an EKG or an ECG looks like is going to be this. And so you have what is called a P wave, which is going to denote when the atria are depolarizing. You have this QRS complex, which is going to denote that the ventricles are depolarizing. And then we have a T wave at the end, which is denoting that the ventricles are repolarizing. So atrial repolarization is going to be hidden. It's inside this QRS. It's masked by the depolarization signal that's going to be there. And so P, QRS, and then T represents one complete cardiac cycle. Although when you look at them, typically what we do is we measure heart rate by looking at how many R waves we see in a given period of time. So there's actually a fairly, if you like working with older individuals, there's a good career path that you could think about taking would be working in cardiac rehabilitation. One of the things that we know is that when people have heart attacks and they have cardiovascular disease, one of the single most effective treatments is exercise. And if you can learn how to read and interpret EKGs, and you like working with older individuals, the insurance reimbursed standard of care for people post heart attacks now is they go and they exercise under someone's supervision with an EKG on. And so almost every hospital or relatively large hospital in the country now has its own cardiac rehabilitation unit. There are some private facilities that have cardiac rehabilitation units. Depending upon what you're doing in general, people that do cardiac rehab, if you have a master's degree and you're the director of the cardiac rehab, you probably make more money than a physical therapist does. You probably make more money than I do as a professor. Now, admittedly, you are working with people that may have a heart attack while they're exercising, but there's some really good jobs that you can get. You can get a job working in this just out of undergrad with a degree in health and exercise science. You need a couple of certifications, but there's a lot of jobs and things that are there because we have lots of people that have cardiovascular disease. Okay, but if you want to know more about this, you will actually put all the electrodes on. You will watch how it changes during exercise. You will get a chance to interpret some of those if you take exercise testing and prescription with Dr. Kellawan or Dr. Larson. Okay. Okay. So this is just showing the things that are going to underlie all of that. The EKG. So now we're going to transition to some variables, some things that we can measure as it relates to both how often the heart is contracting and how much blood is getting moved around out of the heart, either every time it contracts or over some kind of static period of time, like 1 minute. And these variables, okay, heart rate, stroke volume, and the product of those two, cardiac output, are going to be really, really important clinically, so that if those numbers are low, especially stroke volume and cardiac output are low, that can denote that there's cardiovascular disease and problems. And the higher those numbers are, they're going to correlate very strongly with your endurance exercise capacity. Okay, so stroke volume especially is going to be a variable that is very highly trainable. So we'll kind of get into what that is and then how it can move around. Okay, so if heart rate is pretty self-explanatory, it's just simply the number of times that the heart beats in a given minute. Stroke volume is a little bit more complicated. Okay, stroke volume represents the amount of blood typically measured in milliliters. Okay, typically measured in milliliters that is ejected from the left ventricle into the aorta every time the heart contracts. Okay, so in an average college-aged person at rest, stroke volume is somewhere between 80 and 100 milliliters. Okay, I usually do an example in class, but it's gotten to a place, so I'll ask it here. How many of you have ever used a real camera in which you put 35 millimeter film? Anybody? Anybody ever used a camera? I can't see everybody. I'm looking. Anybody? No? Okay. My wife and I actually we still have little disposable cameras that we've not developed from our wedding, which took place in 2003. But in the old days, before your phone was a camera, you had to put film in a camera and you would do things. And the problem with film is if you want to get it developed, if it gets exposed to sunlight, then it ruins the film. And so 35 millimeter film would come in these little canisters that they were plastic and they were black and they had a gray top on them. And those are about the size that you could fit about 80 milliliters of fluid into them. So what I'm now holding in front of me is a 16.7 ounce Mountain Dew Zero Sugar bottle. This is 500 milliliters. So imagine that every time the heart contracts, okay, it ejects. Maybe in me, I'm probably slightly more fit, knock on wood, and slightly above average in actual size. So my stroke volume is probably about 100. It ejects about from the bottom to about right there, okay? About a fifth of this every time the heart beats. So that's how much blood you're going to eject, okay? So we can calculate this. Stroke volume is the difference between two other variables, okay? And so you can imagine, and I'm going to do this, I'm ready for today. I actually have two different bottles out here. So imagine that the left ventricle has a certain amount of space in it, okay? It has a certain volume when there is no blood that's going to be contained in it. So imagine then my Gatorade bottle here. This is my left ventricle, okay? I've got blood coming, so during diastole, the left ventricle, okay, it's just contracted, it's somewhat empty, and it can hold a certain amount of fluid. So during diastole, the atria contracts, the left atria contracts, and that pours blood basically into the left ventricle, right? At the end of that filling, at the end of diastole in the left ventricle, we have the amount of blood in there is called the end diastolic volume, okay? The end diastolic volume, just before it contracts. Then it contracts, so I can squeeze this one pretty easily. So you can imagine, here's my ventricle, I've filled it up, then the ventricle contracts, and it squeezes in on itself, and it ejects out a certain amount of blood, okay? And then as soon as it stops contracting, or right at the end of the contraction, there is a certain amount of blood left in the ventricle. That's called end systolic volume, okay? And so stroke volume is the difference between those two variables. How much blood was in the left ventricle when it started contracting, and then you subtract out how much is left at the end when it's done, how much is left. The difference between those two is how much was ejected, okay? Does that make sense, everybody? That's how we arrive at stroke volume, okay? Related to stroke volume is something called ejection fraction. An ejection fraction, this is going to be in addition to sort of how much does stroke volume go up or down as you train or you have cardiovascular disease. Ejection fraction is also very sensitive to proper function of the left ventricle. Ejection fraction represents if you were to fill the left ventricle entirely, okay, what percentage of the blood in there is going to leave during contraction of the left ventricle, okay? So ejection fraction is end systolic volume divided by end diastolic volume. At rest, in a person with good or normal cardiovascular function, you pump about 2/3 of the blood out of the left ventricle at rest every time the heart beats, okay? So there's still about 1/3 of that volume left. When we exercise, stroke volume increases, okay? Left ventricular size is not going to change, so as we eject more out, our ejection fraction goes up. When you have some kind of cardiovascular disease and you get weakening in the left ventricle strength, okay, because of some kind of damage or impairments or high blood pressure or something, then ejection fraction falls. And that's going to be a really important measure of things for us as well. Okay. All right. So we talked about heart rate. It's just the number of times that it beats. We've learned what stroke volume is. So when we multiply those two things together, all right, wait, hold on. Can I ask, what was the ejection fraction equation? So it is going to be end, I'm going to try to type here, end systolic volume divided by end diastolic volume multiplied by 100. Okay, that would be the way to calculate ejection fraction. Good question. So cardiac output is heart rate multiplied by stroke volume, and we measure it over the course of 1 minute. So how many times does your heart beat in a minute? So we'll go back to our previous example with Cameron. So we've got 50 beats per minute, okay, at, let's just say, 80 milliliters per beat, okay? That's going to work out to 4,000 milliliters of blood that are going to be ejected over the course of 1 minute. So we can move the decimal places, and that works out to be 4 liters of blood, or 4 liters of cardiac output per minute, okay? So we typically express cardiac output in liters of blood that are going to be circulated per minute. In an average size college-age person, the smaller you are, the lower your cardiac output tends to be. Okay, it's somewhat related to body size. Your blood volume is somewhat related to body size. Your heart size is somewhat related to your body size. Normal cardiac output is going to be somewhere between maybe 4 and 6 liters per minute at rest. Okay, so ladies, you all tend to have a little bit smaller cardiac output than men just because you're smaller, and so your heart size tends to be a little bit smaller. People that are sedentary also have smaller hearts than people that are very, very active. And so the more sedentary you are, the lower your cardiac output is also going to tend to be. Okay. When we exercise, heart rate goes up, stroke volume goes up. And so typically we're going to see somewhere between maybe a 4 to 6 or 7-fold increase in cardiac output during very high levels of exercise. Okay, so if you have a resting cardiac output of about 5 liters per minute, at maximal kind of running, you may be able to increase your cardiac output to about 20 liters of blood being circulated per minute. If you are an elite distance athlete, you may be 5 or 6 liters at rest, and you may be anywhere from 35 to 40 liters per minute during high intensity exercise. Okay, so cardiac output is going to represent to us over the course of a minute how much blood can we basically circulate by a muscle. okay? The more blood that can move past a muscle, then the greater the chances that we can diffuse oxygen from the blood into the muscle. The greater the chance that we can diffuse carbon dioxide from the muscles back into the blood, okay? The higher the cardiac output, the more blood that's going to go to the lungs so that we can, again, bring oxygen in and get CO2 out, right? So that's why increasing cardiac output and our ability to increase it and make it as large as possible is going to be related to aerobic exercise performance in people that have cardiovascular disease. Because they have improper left ventricle function, they have a very low stroke volume. So their overall cardiac output is going to be very low. And that's going to be why they're going to have a hard time walking or jogging and those kinds of things, because it's going to be related to the fact that their cardiac output is low. And so they cannot take and present enough oxygen to their skeletal muscle to be able to generate sufficient energy to supply their muscles to be able to walk or to run or something like that. Okay? Okay. So that's cardiac output. So if we know kind of what the variables are on how we measure how blood is going to move, the next thing that we need to understand is how is the blood moving, or why is the blood moving in the way that it does, okay? And so this is an interesting thing to me, in that inside your body, you're going to, when you breathe, you're going to move air, and then when your heart beats, it's going to move fluid, and they're both going to move due to differences in pressure, okay? And so we can measure the pressure that the blood is exerting on a particular blood vessel. Typically, we're going to measure blood pressure in the arm, here in the brachial artery, okay? But you could measure blood pressure inside the atria, or inside the ventricle, or inside the aorta, or down in a capillary, if you'll let me run a catheter in and try to make those measurements, okay? We typically express blood pressure as two numbers, okay? Systolic pressure, so the pressure exerted on a blood vessel wall while the left ventricle is contracting. So systolic pressure over diastolic pressure. So the pressure exerted when the heart is not contracting, okay? Systolic pressure is going to generally be higher than diastolic pressure, and that's a good thing, because if it's not higher, then we're not going to be able to move blood, okay? If you work in cardiac rehab or you do anything with a cardiologist, exercise folks have gone away from this, but you may encounter a variable called MAP, or mean arterial pressure. Mean arterial pressure attempts to account for the different amount of the cardiac cycle that is spent during systole and diastole. So mean arterial pressure takes systolic pressure once, diastolic pressure twice, okay, because you spend about 2/3 of a cardiac cycle in diastole. You add those three numbers up, you divide by 3, and you're going to get kind of a weighted average of what pressure that blood vessel is seeing. We used to use this in the 80s and 90s a lot more as a measure of stress placed upon the heart, stress placed upon the arteries during exercise or at rest. It has fallen out of favor to some extent. They tend to focus just much more so on kind of systolic over diastolic, okay? So as we move blood through the body, blood is going to move from an area of high pressure to an area of low pressure, okay? So when the atria contract, pressure is very high. The ventricles are relaxed, pressure is very low. Blood moves from the atria into the ventricles. To move blood around through your body, when the left ventricle contracts, it's going to generate the highest possible pressure of blood that we can see anywhere in the body is going to be inside the left ventricle, okay? Left ventricular pressure is going to rise. As soon as left ventricular pressure exceeds resting diastolic pressure in the aorta, blood will begin to move out of the left ventricle into the aorta, okay? As pressure rises in the aorta, that's going to push and move blood along, okay, down the vascular tree. It's going to move from the aorta down the arterial tree, from the arteries into the arterial. So as we move along, as we move out towards muscle, out towards other tissues, from arteries into arterioles, pressure is going to go from being very high and it's going to gradually decline down. That difference in pressure allows and drives the blood moving from the heart out to different tissues, from the arteries to the arterioles, out down to the capillaries, and then from the capillaries into the venules and into the veins, and then back to the heart, okay? So in order to maximize our ability to move blood around in the body, we need to maintain some relatively high, okay, systolic pressure, and we want to maintain relatively low pressures out around muscle or the digestive system or the brain. We want to have capillary pressures and venous pressures that are very low so that that gradient is as big as possible, okay? So you guys will see when we talk about the responses to exercise that one of the things that happens with exercise is systolic pressure goes way up, okay? The left ventricle contracts more and more forcefully and raises left ventricular pressure, which raises aortic pressure. So systolic pressure goes up, diastolic pressure stays about the same, so the gradient gets bigger and bigger. And that's going to force more blood out of the heart, force blood faster and faster in larger volumes out to our peripheral tissues, okay? One of the other things that we see, and one of the problems of cardiovascular disease, and we'll get into kind of the how and why of this when we talk about it, is that one of the forms of cardiovascular disease, probably the most common, is something called high blood pressure. And so in a person that has high blood pressure, their resting systolic and diastolic pressures are going to get shifted upwards. And so when that happens, that's bad, because that means that the left ventricle must generate a higher and higher amount of force to raise the pressure in the left ventricle in order to overcome aortic pressure, okay? And so the heart has to work harder, and it makes it more difficult to eject blood out of the heart. And over a long period of time, if you chronically have high blood pressure, then the heart has to work exponentially harder, and that can be bad for us in the long run. And we'll talk about the how and why of high blood pressure when we get to cardiovascular disease. Okay. Any questions about that, guys? I know I've kind of thrown a lot of information. I've been doing a lot of kind of talking at you today, I feel like. But that's kind of what's going on with that. We're going to shift now into talking about the blood, okay? There appears to be a question. Tyler wants to know if I'm getting choppy for anybody else. Okay, the two of y'all that I can see are saying no. So Judy says it's working for her. Okay. I'll try to lean a little closer to my microphone and not be as demonstrative with my hands and everything on all of that. My wife tells me that I talk with my hands in a lot of ways. I do a lot of this and I move, and my daughter is picking up on it now. We listen to music when she eats all the time, and we listen to like the music from like Frozen and other Disney movies, and when they hit sort of a crescendo, I kind of, you know, like act like I'm an opera singer. I'm like, yeah, I can't sing at all. My voice is terrible, but we do this. And so now the music comes on and my daughter just goes like this, and she puts her hands up. It's very funny. Anyway, so I'll try to keep my hand talking to a minimum, and I'll get a little closer to my microphone. Okay, so Tyler's going to try to relog in. All right, so we're going to shift now to what I feel like, and Dr. Mike will talk a lot more about this in exercise physiology, but as an exercise physiologist, as a person that knows enough about the cardiovascular system to be dangerous, I think that we, in a lot of instances, undersell the importance of blood and the characteristics of blood in cardiovascular function, and in exercise performance. Okay. Has anybody seen? Did anybody watch the very recent documentary they showed after the Michael Jordan documentary on ESPN on Lance Armstrong? Okay. If you know, wherever you are, or if you've got somebody's password to log in, if you can get on and watch, it's an ESPN 30 for 30, you can go onto their app or onto their webpage, and if you get ESPN on your cable thing, you can log in with your cable credentials and you can go and you can watch it. I would encourage you to do so. If you have Hulu or you have Netflix, there's another thing on Hulu. It's called Icarus. It's a documentary that is fabulous. But the thing Lance did to cheat was he manipulated his blood. Okay, and so we can have these very powerful effects on exercise performance by changes in kind of what's happening with our blood. So to start off, what is blood? Blood is a fluid, but it's a viscous fluid because that fluid is going to contain cells. Okay, so typically we talk about blood as being plasma, which is mostly water. Okay, there's a few other things that are going to be in there, but we have plasma, which is mostly the water in the blood, and then what we call hematocrit, which is going to be the red cells and the white cells and the platelets that are going to be contained in the blood. Okay, so plasma also there's some plasma proteins, there's a few other things, but plasma is almost entirely water. So blood is a liquid that is maybe 50, 60% water, and then a little bit of protein, and then the other maybe 40 to 45% is going to be red blood cells and white blood cells. Okay, so one of the things that we need to know about blood is we all have a certain amount of it in our body, and we all have a unique to us distribution of how much water is in our blood and how many red blood cells we have in our blood. Okay, so let's use an example. We will say, just because I can see here that maybe Corey has, we'll say 4 liters of blood in her body. Okay, blood volume, the amount of blood in your body, is somewhat dependent upon both body size and your state of aerobic training. So the bigger you are, the larger your blood volume is going to tend to be. And the more aerobically trained you are, the larger your blood volume is also going to be. Okay? So Corey's putting her earphone in. Corey, do you have a question? You about to make a comment about your state of training or something? We should ask. No? Not, is your training not good?
I don't have a question. I was just trying to listen more.
Trying to listen. Oh, so you haven't been listening.
I have been listening, but Stefan just came in here and was talking to me, and then
Tell
you said my name.
to stop distracting you.
Okay.
So, okay, just because he's seen this once, he's going to have to teach it to you when you're not listening. All right, so Corey has, let's say, 4 liters of blood, okay? Most people, your blood volume is going to be very close to equal to your resting cardiac output, okay? So let me look at this. How much is this? So this is, my Gatorade bottle is a quart. So if Corey has 4 liters of blood, she's got about 4.5 of these full of blood in her body. So she would have 2 2-liter Coke bottles of blood, which when you think about it, really doesn't seem like it's really not that much, okay? It's really not that much. Bigger people might have 5 or 6. Very large, highly trained endurance athletes, like if you look at cross-country skiers or some rowers and those things that are these really big, 6'3", 6'4" guys that might weigh 220 pounds or something, they may have 7 or 7.5 or 8 liters of blood in their body, these giant blood volumes. Okay? But then also, so Corey has 4 liters of blood, but she also may have this very distinct to her distribution of red blood cells and white blood cells, so hematocrit to plasma. So let's say that Corey's hematocrit percentage is 40%. So her blood is 40% cells, 60% water. Okay? And so the amount of red blood cells, the total amount of red blood cells in your blood, okay, which would be your hematocrit percentage multiplied by what your total blood volume is, determines the total number of oxygen molecules that can be bound and transported in your blood at any given time. So you can imagine a scenario whereby if I have more blood and a higher percentage of whatever blood I have is red blood cells, then I can carry more oxygen in that blood, which means I can have more oxygen to take out to my muscles or to take out to my brain or to take back to my heart to allow my metabolic rate to be higher and higher, okay? And so one of the single most powerful ways to become a better endurance athlete, if you want to get big and strong, take anabolic steroids. If you want to become a better endurance athlete, you take something called erythropoietin, which you can either take synthetic or sort of like a natural hormone that's produced by your kidneys, and it synthesizes and tells your body to make, tells your bone marrow to make more red blood cells. And so people that take EPO, they may be much closer to, say, 50% of their blood volume is going to be 50% of their volume is going to be red cells. And so that's going to provide a very marked advantage to a person that's only 40% in their oxygen carrying capacity. Okay? As far as we know, when you cheat and you take synthetic EPO, it's hard to get over about maybe 51 or 52% as a hematocrit percentage naturally. You can get this naturally by going to altitude. So we can all go like live on Pikes Peak for about a month, and our red blood cell volume will naturally increase. You take EPO, you can get over 55% of hematocrit. It's both very good for exercise, but also very, very dangerous because your blood gets really, really sludgy and it becomes hard for it to circulate, and the number of blood clots that you're liable to form, especially at night when you're sleeping, is going to go up dramatically. Okay, so that's why understanding how much blood and the percentage of that blood that is hematocrit, okay, is going to be really, really important, because it's going to play a role in determining how much oxygen you can carry, but also total blood volume is going to be really important for determining stroke volume. Okay, so let me go on to the next slide. So the reason that hematocrit is important for carrying oxygen is that red blood cells are where we carry oxygen. They have these molecules, what we call hemoglobin, on them. Hemoglobin has iron in it. Iron is has a very strong positive charge, and that means that it's going to try to attract oxygen and hold on to that oxygen very, very powerfully. Okay. Each hemoglobin molecule can bind 4 molecules of oxygen. Each red blood cell has about 250 million hemoglobin molecules on it. So a single red blood cell can bind 1 billion molecules of oxygen. So you can imagine that you have trillions and trillions of oxygen molecules in your blood at any one given time. Okay? By having hemoglobin in our red cells, it increases our O2 carrying capacity. I've forgotten the number off the top of my head, but it's like 10 or 15 fold or something. So if we have people that are that have sickle cell trait or sickle cell anemia, so that their red blood cells don't have as much hemoglobin, their red blood cells are somewhat misshapen, then their ability to carry oxygen goes down a lot. Okay. And if you have sickle cell trait, that's really good because it can protect you from malaria. We tend to see it in folks who come from populations that are descendant from populations that live near to the equator. So folks of African descent and folks of South American descent, kind of in Brazil and those areas, have higher rates of sickle cell trait, but it does reduce their oxygen carrying capacity. So it's kind of a trade-off. Okay. So to finish up today, I want us to talk about how are we carrying oxygen, how are we carrying carbon dioxide in the blood, and then how are we going to move that around in the body, okay? So we carry oxygen. Yes,
sorry.
Judy. No, please
I have a
ask away.
question. So does that mean people who have anemia, like, don't a lot of them have trouble breathing sometimes?
So part of what they're doing with their breathing, so if you're anemic and you lack iron, you may have a lower hematocrit content, and so you may have a hard time clearing CO2 to the same extent that a regular person does, which will become a little more apparent because we actually can carry some carbon dioxide on our hemoglobin, and it's a little more difficult for those people to clear CO2, and the increased CO2 in the blood is what drives the increases in breathing. And so there may be some issues with all of that. The bigger issue in folks that are anemic is that your endurance capacity goes down because you can't carry as much oxygen. So.
Okay, thank you.
Mm-hmm. And my wife has always been, anemia is fairly prevalent, especially in women, especially those of you ladies that are kind of on the more kind of smaller or petite side. It's very, very common. They're always telling my wife to take an iron supplement, and the iron upsets her stomach. They were very concerned about that when she got pregnant. And so, there are issues. In most kind of anemia in women, if you don't have an eating disorder, maybe you're not anorexic or you're not somewhat undernourished, it's kind of a weak thing, and it's not that big of a deal, but it can become a very, very big problem. So 98% of the oxygen carried in your blood is bound to hemoglobin. And I apologize, you got about 2% that's carried in your plasma. So by having hemoglobin in the blood, it increases the O2 carrying capacity by about 70 times. So I was way under on my number on the last slide when I said I had forgotten. Okay, so about 70 times the carrying capacity because we have hemoglobin. So having more hemoglobin by having more and more red blood cells can be very powerful for letting us carry more oxygen. More oxygen is good for exercise. Okay, now there are instances in folks that have had chemotherapy and things where they're going to have low red blood cell counts, and we will give erythropoietin to normal people maybe that aren't competing in endurance athletics to try to raise their red blood cell count and allow them to have more oxygen, but that's just from a health standpoint, not so much from a performance. Okay, because of the hemoglobin's affinity for oxygen, as long as we are at a relatively low altitude, pretty close to sea level, hemoglobin saturation in people that have good or normal pulmonary function, okay? So you don't have chronic obstructive pulmonary disease, you don't have asthma, you don't have emphysema, the hemoglobin in your red blood cells tends to be at somewhere at about 98 to 100% saturated. And all that means is you have a shit ton of oxygen bound on the hemoglobin in your bloodstream, okay? Many of you may have gone to the doctor and they put a little device on your finger and it tells you what your blood oxygen saturation is, okay? That shines a near infrared light into your finger, and it's measuring the amount of oxygen bound to the hemoglobin in the capillaries in your finger, and it tells us what your pulse oxygen is, okay? If you have improper pulmonary function, your O2 sat on your hemoglobin can fall, and that can become dangerous. If we go high enough, to a high enough altitude, I'm talking about going to the Himalayas, and we're going somewhere above base camp if we're going to try to climb Mount Everest or something, then hemoglobin saturation can fall into somewhat dangerous levels. It will fall a little bit, like if you go to Pikes Peak, you go to Colorado or someplace and you try to exercise, there's less air, there's less oxygen, so there's less O2 partial pressure, and your hemoglobin sat will drop a little bit, but not so much that it becomes dangerous. But if you go high enough, like you're climbing Mount Everest, it can become dangerous. Okay. Which is part of the reason why half of the people that try to climb Mount Everest die. I don't know about you guys, but I have no, like, I don't care that it's a great and wonderful achievement. I don't really want to die. So if oxygen is carried a little bit in the plasma and mostly on hemoglobin, the CO2 that our muscles make that we need to clear, that we need to breathe off, it's going to be carried in a slightly different manner, okay? So we have a slightly higher percentage of CO2 that's going to be dissolved in the blood than oxygen. So somewhere between 7 to maybe 10% of CO2 that you make in your muscles or in other tissues from aerobic metabolism is going to be dissolved in the water in your blood. Okay, you're going to have somewhere between maybe a fifth to a third is going to swap places with oxygen on the hemoglobin. It forms something called carbaminohemoglobin. All right. And so when you've unloaded the oxygen, you can load some CO2 on there, which that's going to help us carry more CO2 and remove a little bit more CO2. And then the majority of CO2 carried in your blood is going to be carried as something called a bicarbonate ion. Okay. And so when you dissolve carbon dioxide in oxygen, again, more chemistry, okay, while you guys may not use the anatomy that much, the chemistry that you all do take, or if you take biochemistry, if you want to be an exercise physiologist, we do a lot of biochemistry. When you dissolve CO2 in water, it forms something called carbonic acid. And carbonic acid is a weak acid. Well, you've made the acid. That acid exists in the plasma, which is water. And so then the carbonic acid wants to dissociate into hydrogen ions and a molecule of HCO minus, which we call bicarbonate. Okay? Bicarbonate may ring a bell to some of you. Okay? I actually had something that had bicarbonate in it last night because my stomach was upset. Anybody know what that is? What I might have taken last night because I had an upset stomach?
Bicarbonate soda.
Okay, bicarbonate of soda, that's one thing, yes. That's just CO2 right in your drinks. I took Tums last night. There's bicarbonate in Tums, or excuse me, milk of magnesia or Malox or something. When you have an upset stomach and you think you're making extra stomach acid, which is not an unusual thing for me given my stress levels, then you need to take something that has bicarbonate in it. So what bicarbonate does is bicarbonate functions as a buffer. Bicarbonate actually is a base, okay? And so the bicarbonate in your blood floats around and it soaks up, if you will, the extra hydrogen ions. And when it does that, then it will soak up some extra hydrogens, and then it comes back to the lungs and it releases its CO2. And it takes the hydrogen, it kind of runs this reaction in reverse, that it binds up extra hydrogen, and then that hydrogen, it sort of forces this reaction back to the left, and we make water and CO2, and then you can breathe off that CO2. So you use the bicarbonate to buffer acidity. So that can be useful if you have an upset stomach. It can also be useful, which is part of why we talked about this morning, if your muscles are making lactic acid. You can use the bicarbonate in your blood to buffer the hydrogen ions that are produced, the acidity that is produced by lactic acid. We know if you eat a bunch of Tums and then go do repeated sprinting exercise, your performance goes up, okay? Because having all of that extra bicarbonate in your blood allows you to better buffer the lactic acid and prevent the lactic acid from making your muscles burn quite so much and having it inhibit normal metabolic and cross-bridge function. So the amount of bicarbonate that you have to eat, though, to get to that place where it will have a positive function is a very, very large amount. And when you have bicarbonate at that level, if you guys ever look on the back of a bottle of Malox, it says take two teaspoonsful or something if you have an upset stomach, and then it will say take 4 teaspoonsful if you are constipated. So if you have enough bicarbonate, then it becomes a laxative, and so you will run better or faster longer, but you may be running to the bathroom to have to go. Okay. All right. So there was a question about all of that. Are Tums and Alka-Seltzer the same thing? So they are similar-ish. Okay. The Alka-Seltzer is also going to have bicarbonate in it. yes, and it will function in a lot of the same way, where it will buffer the additional acidity from stomach acid and those things. So yes. Okay. Next slide. Here's gas exchange at the tissue level, showing those things. Okay, so let's go ahead and stop here for today, guys. All right, we'll pick up tomorrow talking about blood vessels and the vascular system, and then we'll do some functional physiology where we put heart, okay, blood vessels all together and kind of get at kind of normal function and how that changes during exercise. Okay. Does anybody have any questions?
I have a question about the lab.
Okay, fire away, please.
Since we're not collecting, actually collecting our data, and since I don't see any, I only see the graphs for the data that we have, and not really like a, like an experimental sheet showing methods. How do you want us to do methods and like introduction for our report?
So do an introduction, Preston, where you write a little bit on kind of what the purpose of the lab in theory would have been if we'd actually done it. Like, why is it important to measure strength? Why is it important to measure local muscular endurance? That type of thing. Okay, so write a little brief introduction. As far as the methods go, you guys don't have to write a method section. Okay, you don't have to write a method section because you would really just be copying and pasting from the lab document in there. And since you guys didn't, you did the push-ups and the sit-ups, I guess, but since you didn't do the other ones, you can't really offer any insights and context on your experience trying to measure your 1 rep max, or your experience trying to perform the grip strength thing. And so it really just kind of becomes very redundant. Okay.
All righty.
Anybody else have questions about lab? Again, if you haven't gotten your critique turned in, let me know, send me an email, and I will try to open the critique thing back up. The fact that it is now late, I made arrangements with a couple of you so that you could have access to our video to check a couple of things. But if you've not turned it in at all, first, I guess, go ahead and email the thing to me and then tell me, and I'll see if I can I can open the submission system back up so you can turn it in online and we can run it through Turnitin. Okay. All right. And you have until, I think, tomorrow, it's either at 5 or maybe tomorrow at midnight to turn in the labs. You've got a longer period of time. The lab is not due at class time tomorrow. You've got more time.
I have a question.
Yes, Kylie.
Well, not exactly, but if we have questions later, do you prefer like an email, or can we like text you or call you?
No, I would prefer that you text me. Text me and let me know that it's you at that phone number. And then as long as I am available, which as long as, I should be for the most part, usually I can talk on the phone while chasing my daughter around, then we can talk. Because usually depending upon what the question is, it's easier for us to get through it through an actual conversation rather than me trying to explain something over text message.
Okay, and then I'm kind of confused. So I pulled up the lab that you had posted.
Mm-hmm.
I'm confused on how we're supposed to get the averages for these.
Okay, so under the lab section, there's an Excel file, and I think it says CB Lab 1 or Lab 1 CB, something like that. You need to download and open that Excel file. And in that file, these are the data from both sections of my class from last fall. So there's data from like 45 or 50 people in there. And there is a column that says if they were a male or a female. There's a column that says here's what their 1 rep max was. There is a column that says here was their right arm grip strength, their left arm grip strength. So you want to take those data, okay, and split them up based upon men and women for each of those variables, and then calculate the average from that data.
Okay, I just didn't see this part of it. I only opened the other file.
Okay, cool.
That's helpful. Thank you.
You got it. Anything else, guys? Nope. Okay. Well, then I will try to get the lecture from today posted on YouTube this afternoon. It takes forever sometimes to get them loaded up on YouTube, which I don't really understand, but I will try to get it posted, and then I will just see the rest of y'all tomorrow. Okay?
Sorry, I have one more question.
Oh, of course.